Welcome to the Business Talk, a global podcast series that highlights distinguished faculty members and their impactful scholarly contributions. I'm Deepak, your host from India. We are honored to welcome Professor Barry Katz, Schirin Lucie Richter, and Svava María Atladóttir as our distinguished guests on Business Talk today. Before we get started, I would like to introduce the guests for today's episode. Dr. Barry Katz is a professor of design at California College of Arts and adjunct professor at Stanford University. With a doctorate from UC Santa Cruz and prior education at McGill University and the London School of Economics. A long-time IDEO consultant, he is an internationally recognized design historian and author of influential works including Matic New and Change by Design. Our second guest for today's episode is Schirin Lucie Richter. Schirin is a design strategist and trained anthropologist, formerly with IDEO and now senior partner at Future Medical Systems, where she leads complex, system-driven innovation in healthcare. She specializes in bridging and bringing clarity to complexity, creating meaningful experiences for underserved users while driving business and societal impact. An award-winning contributor with multiple patents, she teaches at leading institutions including Stanford and UC Berkeley and co-authored Discovery Design, Design Thinking for Healthcare Improvement, continuing to shape innovation across industries globally. I am also delighted to welcome Svava María Atladóttir as our another guest on this episode. Svava is a Chief Transformation Officer and Executive Director at Landspítali University Hospital, leading innovation-driven transformation to elevate patient experience in future-ready healthcare systems. With a background spanning IDEO, GE, Abbott, and co-founding Future Medical Systems, she blends engineering, design, and strategy to drive meaningful change. In today's episode, our guest joins us to explore the key ideas from their compelling handbook, Healthcare by Design, a handbook for changemakers. Let's not keep you waiting. Please join me in welcoming to them to our conversation. Professors, it's a distinct privilege to welcome you to all to Business Talk, and we sincerely appreciate your gracious acceptance of our invitation.
Thank you for inviting us.
Thank you. Professor, your book describes healthcare by design as a practical step-by-step guide for clinicians and managers working under intense regulatory and safety pressures. What was the pain point in real healthcare practice that convinced you such a handbook was urgently needed?
Well, I would love to hear my colleagues speak to that. My first observation would be healthcare professionals are working under extraordinarily demanding circumstances, partly because of the nature of their work, which involves life and death decisions under frequently very extreme, unpredictable circumstances, partly for very bureaucratic and institutional and governmental reasons. Healthcare is probably the most highly regulated profession in the world. So there is very little space for innovative and creative thinking as healthcare professionals maneuver among these various constraints. And what we were trying to do was to offer a practical guide which recognizes both the creative impulse of the design tradition and also the realities that my colleagues understand very, very well of healthcare practitioners. Svava, Schirin, do you want to add anything to that?
Yes. Deepak, first of all, thank you for inviting us to the podcast. I'd like to add that I am currently also now working as the special advisor at the Ministry of Health. So the book is very
government of Iceland.
Of the government of Iceland. Thank you, Barry. The book comes at a very timely point, I believe. In my role as Chief Transformation Officer at Landspítali University Hospital, I saw a lot of healthcare workers, clinicians wanting to do really what's best for their patients always. And as Barry talks about, having quite a few constraints. This approach allows for another toolbox tool to be able to do transformation and to make change that's impactful and meaningful in this very regulated and sometimes uncertain environment.
Yeah, and I'm just going to add Also, thank you for having us. Very excited to think about like your questions and putting that into more of a global context again, which was also our goal with the book. And just to add a little bit of nuance to it is because physicians and clinicians in general put so much of their energy into the work, when they see that something isn't working and they want to make the change, then we met many people that then also faced a level of burnout at the level of why can't I get something to be working differently or better? And as we met these people, we could see that some had really figured it out, and those were people that we learned from greatly. But we also met a lot of people that tried to figure it out, in the meantime, got very frustrated. And one of our goals with this book was really how do we share what we've learned and some aspects of how to be successful within a system in a very hands-on and pragmatic way that is accessible.
Professor, there is the book emphasizes that design is as much as about mindset as methods. If you had to pick one mindset shift that makes the biggest difference for a healthcare professional reading the book, what would it be and why?
Colleagues?
Maybe if I could just comment on that. The book has very interesting and relevant, I think, case studies for the clinicians and people working in healthcare to be able to relate to. And as Schirin mentioned, the goal of this book was really to make very accessible the process of going through and using this methodology to make change. So I think this is a really a key aspect of this.
And in terms of your question about the mindsets, it's really the combination of them all. Because what we often find, if we get someone who's very curious, but is not able to translate the curiosity into optimism and has curiosity mixed with pessimism, it actually might work against what we're trying to do. Or they might not be able to have bias to action, where it's really about how do you make things tangible and actually start trying things out. I also want to say that we are operating in healthcare, and by all means, we do not want people to set aside the safety mindset. None of us in this group would ever want anyone to use a prototype and do surgery. No, there's a reason for that rigor, and that is obviously something, a boundary that we kind of want to emphasize how much we respect that. And yet, what we find is how do we carve out spaces that are safe, where a risk-averse mindset can be checked out at the door and a creative mindset can come in to actually come up with new ideas without immediately being judged for, how could you think of something like this? This is irresponsible, right? So how do we create those safe spaces? And that's where these mindsets come in. And that's also where we emphasize to build teams that are high trust, which often in a healthcare environment can also be hard to find, especially when it's about change management.
Very beautifully said. I would add to that the power of the methodology that we are proposing is very much in line with what Schirin just described so elegantly, and that is at the earlier stages, it is very expansive in inviting people to test frequently very imaginative and even unrealistic ideas, but they become progressively more focused and disciplined as the process moves forward to account for exactly the kind of rigors that Schirin just described.
And
My
one other
question,
thing.
yeah,
Oh,
please go
sorry.
ahead. Please
No,
go
no, no,
ahead.
you go ahead.
Yeah. My question is for Svava. The book promises to help readers frame questions and identify opportunities before they jump to solutions. Can you walk us through a concrete example where reframing the problem rather than adding more expertise unlock a breakthrough in care delivery?
Yeah, so I can perhaps speak to just an example where we use this methodology at the hospital. And this was with the patients that are undergoing dialysis for kidney failure. Sort of a straightforward approach from the medical side was we want to improve care for all the patients in this patient group. And one of the things that was always talked about is maybe the need for new equipment, updated equipment that certainly would perhaps benefit the quality of the care and is important. I will say that. But a very costly investment, takes a long time, but maybe doesn't do a whole lot for the patient experience. Meanwhile, at the front line, the patients were experiencing a lot of other things that also mattered that were maybe not addressed in the typical ways. Schirin was part of this work and can speak to it as well. But one of the things that this patient group talked about, for example, was the fatigue around eating the same kind of sandwich every single time they came. They were spending 30% of their time at the hospital many, many days. And this simple shift in how we think about how do they actually feel when they come can change the entire patient experience. So it's not to say that one compares to the other. It's just fixing the simple sandwich problem can already lead to a better patient experience. And while thinking about how do we improve the technology is important, it's more of a long-term strategy in parallel. But the sandwich problem in some ways is only something you would see at the front line and by having a conversation with the patients. Schirin, do you want to build on that?
Yeah, sure. And I think one of the major points there was really to see the patient experience from both sides, because the providers and the nurses in the dialysis unit obviously also have their perspective. And when patients complained about uncomfortable beds, it's not something that they could change, exactly to Svava's point. However, when the complaints arose about the sandwich, one of the issues there was like, well, you're getting a free sandwich. What are you complaining about? And the piece that really made it all fall into place was after we started mapping, what does the life of a patient look like who goes through dialysis, and understanding that you have an on day and an off day, and then you have an on day again, and realizing how much time patients would spend at the hospital, not feeling well, feeling very fatigued. That kind of empathy then really shifted a lot of the perspective also around when do we deliver information to patients. So to give you an idea, and this is also where these methods have been used to understand what is it like the moment you are diagnosed with kidney failure? What is it like in the moment when a patient actually is told you have to start dialysis? And in those moments, realizing from the patient interviews that patients were like, I was like half dead. I could not even hear the information that was given to me. And when we mapped out the entire workflow, it turned out that those were the moments where most information was given to patients. And this is something that we see over and over again when we start mapping the patient experience and the hospital workflows, because both are optimizing for different goals. And the question is, where can we find the goal? Where can we find the win-win so that it's not against the providers, because that's not going to work. We need to support the providers and the clinicians as much as we need to support patients.
Schirin, healthcare by design aims to bring the creative practice of designers into partnerships with a data-driven, evidence-based culture. How do you advise leaders to balance experimentation and prototyping with the legitimate demands for clinical evidence and risk management?
Well, that's certainly the key question that we are facing. One of the things that we were very explicit about in our discussions prior to the book and in the course of writing it was that this is not an alternative to evidence-based, data-driven scientific medicine. That would be a non-starter. So there's nothing mystical about it. There is nothing spiritual about it in the kind of touchy-feely way. We are approaching this as a complement to what has been achieved in 2 centuries of Western medicine, to put it kind of with an ethnocentric bias. So what we are trying to do is add something to a regime that has proven extraordinarily successful, but has limits.
And to put that into the larger context, this really sits neatly in the quadruple aim, where we're going for patient outcomes that we want to improve. We want to improve the patient experience. We want to improve the provider experience at reduced cost. Now, that is kind of an aspect of it that we strongly believe in, because as we know globally, healthcare costs are exploding and healthcare systems are asking more and more the questions of like, what can we afford or how can we solve these problems? And often from our experience, you find answers at the front line, but when there are no pathways to connect the front line to the C-suite, then a lot of opportunities get missed. And I think that's like another aspect of this book where we really wanted to point out ways where at the end of the day, a solution can come from C-suite level in the sense of an invitation to include frontline staff. And when new frontline staff, like nurses, look at a solution, they can see their own colleagues' fingerprints all over it. And it's been many times where we've been asked, like, hang on, who's a nurse on your team? And we're like, nobody. But we invite those voices so that people can recognize their own thought pathways and their own solutions in there.
The book also provides tools for building teams and creating institutional support for innovation. What have you learned about getting skeptical clinicians, administrators, and finance leaders to not only buy in, but actually champion design-led change?
I think, Svava, that's a you question.
Yeah, I mean, I think that for leadership, it's most important to have a good overview of what the service that we're providing looks like from a holistic point of view. We always have limited resources that we can allocate to either new projects or improving care or improving the patient experience. By using this methodology and understanding both the patient perspective and the provider perspective, we can better use these limited resources that we have to create the most optimal possible patient experience at each healthcare facility. I worked in the hospital and I've worked with other healthcare organizations, and how each patient experience from place to place slightly varies is also a result of what the people that bring the care, what they're passionate about, and making sure that that passion has a way of expressing itself in even better patient experience. So at the end of the day, we want something that can give us tools. This gives us the tools to create an overview and an oversight of where we might best make investments and make good impact to our patients.
The book is full of worksheets, charts, and case studies. If a busy hospital department head only had a single afternoon to engage with your material, which one activity or worksheet would you insist they try first? And what would outcomes should expect there from it?
Oh, that's a really good one. I'd say there are a couple of different audiences that we kept in mind, and most of the worksheets are in discovery design. Healthcare by Design is more the stripped down, slim version with case studies. And I would say that's kind of a good starting point for the decision maker audience. And the main reason for it is because, exactly as Svava said, it gives you the overview and it helps you understand what is your overall impact. Discovery design has really been the handbook, and it's also been used in universities as textbook to understand how do you go through an entire process. And from our experience of decades of working in this space, what we learned is if a team within a hospital can secure the mandate from leadership and the budget, then we can come in, the book can come in, and real change can happen. It is much trickier when change makers that I alluded to earlier in this conversation, who are frustrated with what's going on, who then say, you know what, I really want to make a change happen because they don't have the mandate and they're basically doing it in not just 100 to 110% of the time, often it's 150% of the time because that's how demanding their jobs are. So in that sense, for them, we would suggest in discovery design to really read the chapters around scoping because it talks about a lot of details there, how to build a team, how to secure a mandate, how to have these conversations with decision makers. So it's a very different entry point. I hope this answers your question.
Yes. The book talk about scaling solutions across organizations, not just running isolated pilots. Based on the cases in the book, what are the most common reasons promising design pilots fail to scale? And how can changemakers design with scale in mind from day one?
Well, I'm Svava, please.
No, you go ahead.
Well, I was just going to say that in a way, I would actually, I have tended to avoid the use of the term methodology, even though we've used it several times in this conversation. And this will get to your question, I hope, Deepak. I prefer to think of what we are doing as introducing a toolkit. So designers have been in business for about 100 years. We've been obviously building things for thousands of years, but the design profession has existed for about a century. And over the course of that century, we have acquired a lot of, I don't mind calling them tricks, tricks about how to conduct interviews, tricks about how to build prototypes, tricks about how to do design research. And the most important of those tricks in some respects is the insistence upon recognizing every stakeholder in a process, in an institution, in an experience. So what we have in some ways tried to do is recognize the stakes that somebody has who is an ambulance driver or a janitor or a nursing assistant or the chief financial officer of a hospital. These are all part of a continuous chain. And one of the errors, and this gets to your question, I hope, that we've seen again and again and again is a tendency to focus on the most important players. So the most important players might be in the C-suite, or the most important players you might assume are the surgeons who perform exceedingly complex operations. But what we want to say is that they are part of an entire regime. And what the human-centered design approach tries to do is recognize the experiences of every member, every relevant member of an entire process.
Yeah, Sava, you want to add?
Yes, and I'd love to just add to that the challenges that we see are the silos within the organization in many ways. So just making sure to think in systems, as Barry talked about, identifying all the key stakeholders, but making sure that we think about this continuity of care. The systems are sometimes working against us, how we capture the data, how we communicate. So creating this common language about the patient and about the experience of the patient can be very powerful.
The designer's toolkit, what Professor Berry has just explained, ideation, design research, prototyping can be unfamiliar or even threatening in clinical environments. What practical advice do you offer in the book for introducing these practices in ways that respect professional identities and time constraints?
Yeah, that's a very good question because we definitely see that they're like different backgrounds that get exposure. So I want to recognize this because if, for example, a team of product designers, engineers from a medical technology company, a med tech company, a med device company wants to go into the hospital context, then we had that audience a little bit in mind to also give them the tools versus someone who's in the hospital. And since we're mostly talking about change within the hospital and the point of care environment, one thing that is easier for us to say as consultants than for people who work in the hospital because we don't represent the hospital. And this is something that we work with when we work with the teams, because when they go out, so going back to the project on kidney care, we had 3 team members that were hospital employees, and by them going to talk with patients, they had the face of the hospital. So they're representing the hospital versus when we come in and do this work, we're kind of the consultants who can say, yeah, I don't have a clinical background. I'm just trying to learn about such and such topics. So that is definitely something to keep in mind. And then for everyone else is patient care comes first. So even when we say, let's observe what's going on in the pharmacy, let's observe what's going on in the OR, we sometimes have teams, and I'm speaking here more about like the medtech or digital health teams that are external to the hospital, like, I have my 1 hour here, I want to get the most out of it, where our advice really is like, no, you are not important. You are allowed to be in this environment. People have trusted you enough to give you permission, but that does not mean that your agenda comes first. Patient care comes first, and then you make sure that when there are moments to ask your questions, and also in the book, we go into the details of how much you can learn from just observing. So even when you can't have the opportunity to talk with that surgeon or have a conversation with somebody else, just by taking in the environment and looking at the cues of what is left where, or how do people handle a packaging of a device that gets used in the OR, and where does it get moved to, and what are the kind of conversations that are taking place. People can already learn a lot from that.
Healthcare by Design highlights the experiences of patients, families, clinicians, and organizations. Is there a story from the book where a design intervention simultaneously improved the patient experience, clinicians' well-being, and organizational performance? And what made that multi-stakeholder win possible?
I think that's the story of Med's time. Do you agree?
Yes.
Yeah.
Yes.
Do you want to give the overview, Svava?
Yeah, so the story of Med's time, I think, is very relevant here. The premise of the project was to reduce the errors with administrating medications in hospital, at the Children's Hospital at Stanford. And I think that's the example that it brings is a nice one of how it really provided benefits to everybody. This was a case study that shows how we found ways to keep the parents, who are the primary caretakers outside of the hospital, keep them engaged when the child is in the hospital. Also to create tools for the nurses to help them stay safe and to create sort of direction around how to administer the medications. So with the parents present, and of course to the patients themselves, who are then the beneficiaries of this added safety and change processes. So it's a win-win-win.
Yeah, and we identified multiple ways of improving medication safety. And it then was also a question of what's the organization ready for? One intervention was about the pharmacy, but right in that moment, there were lots of changes happening. So the pharmacy was not the right place to start with. And that's how the Children's Hospital was chosen as one of the places to start out with. But then there was also this question of, well, this is just a concept that we derived from patient interviews, provider interviews, observations in the hospital. And the question was, what's in it for the nurses? And it was through participatory design workshops to really sit down with the nurses to identify what are the additional things that are important to you. From a risk perspective and a hospital liability standpoint, it is all about like medication safety, sticking to the protocols. But the piece that we discovered through this process was what the nurses don't know, and I'm going here a little bit more into details, is The nurse doesn't know, does the child need the tablet halved or crushed, or can the child swallow a tablet? Does the child need applesauce with it, chocolate syrup, or is just water enough? And those were these moments that led to additional interruptions. And the literature shows that additional interruptions lead to more medication errors because you get distracted. And one of the goals was to really reduce the number of distractions. So we observed one of the nurses leaving the patient room because she's looking for the pill crusher and being asked, hey, can you sign the birthday card for this and this colleague? Now, here we're talking about like an everyday moment, yet it's happening at a moment of medication administration. So that was the moment where the nurses actually came up with these ideas of how to gather that information so that they would have less interruptions. And it was also because then their work would be, their workflow would be smoother. And what was fascinating for us was how new nurses who saw this intervention could immediately tell that a nurse had designed that. Because they were like, nobody else knows that you have to search for that pill crusher or pill halfer, and there's only like one device out there, and it's always missing, and it's never at the spot where you want it to be. And because it gained momentum, and it really then started also gathering the attention of the chief nursing officer, it then gave permission for this intervention to be more deeply rooted within the organization. And as a next step, we heard that there was an IT nurse, and we'd never heard of IT nurses before. We hadn't come across them. Turns out they can make changes to the electronic health records, and they were able to create an epic, what is called a MAR node. And in that MAR node, this new process is anchored. So when a child today gets admitted to Lucille Packard Children's Hospital at Stanford, at admissions, questions like, how does your child take the medication are captured in the electronic health record. So when today the nurse then goes to room 3 and has the medications with them, they also then recognize immediately, oh yeah, chocolate sauce, pill crusher, I'm ready, which then also leads to the steps of having everything ready and less distractions and interruptions.
I think I would, if I may also add to Schirin's wonderful example, what she just described is a really key design method, and that is the creation of design principles. So a principle is not a solution. A solution is what we are aiming for at the end of the day. But a design principle in this case is reduce interruptions. So the larger problem has to do with medication errors and avoiding them, and we are trying to solve that problem. But along the way, what a design thinker will introduce will be a set of guidelines, or what I just referred to as principles, which we will follow as a means of getting toward that solution. So larger problem, reduce medication errors, one of a number of design principles to get there, reduce distractions along the way.
Professor Berry, Schirin, and Svava, I would like to conclude this episode with one last question. If a listener finishes your book and wants to start a design for healthcare improvement movement inside their institution, what first 90-day roadmap would you recommend? Drawing on the chapters, tools, and case studies you have assembled in Healthcare by Design.
I'd say
Well, please go ahead.
No, you go ahead, Barry.
All I was going to say there is jump in. So we offered what looks like a step-by-step methodology. I would actually recommend taking that with not so much a grain of salt, but a greater degree of flexibility than many readers may assume. So it's not a question of boom, 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 and at the end of the day, you've solved the problem of kidney failure or medication error or something like that. We are encouraging people to experiment with a process and make it relevant to the institutional context in which they are working, not us, but them. So to my mind, that means jump in and begin experimenting with concepts, see what works within the context of your organization, and move forward with it.
Yeah.
Yeah.
And I would say storytelling is a very powerful skill and important in the clinical setting when it comes to this as well. So if you are a healthcare provider who is working in an institution, wherever you are in the organization, if you can share the stories of how you might be able to, of what the challenges are that the patients that you are serving are facing, that's a very powerful tool to share with leadership, to get permission to explore that further, or to start to find possible solutions to improve the experience of the patients. So I would say the first start is just observe, listen, and then tell those stories.
And I would take it to a level even more granular, follow the money. Like the medication safety project was possible to do because of medication error and liability lawsuits causing a lot of pain to the legal department. So find out what is causing a lot of issues in your organization and then figure out a way of how to address that problem in a creative way, in a human-centered way, so that it doesn't take away more and more resources just because we now have something that is draining the budget, but that that you and your team can actually look at it creatively and see how else can it be solved. And one thing which I think gets back to the mindsets is really the optimism of believing that there is a solution and believing that you can implement it.
Thank you, Schirin, Professor Berry, and Svava for joining us on the Business Talk episode. It has been a privilege to learn from your experiences and insights for designing better future in healthcare. Thank you once again.
Thank you for inviting us.
Yes, thank you.
Thank you for having us.